Is a graduate of UMBC with a BA in biology and has undertaken graduate studies at George Washington University and at the National Institute of Health in biochemistry, immunology, and epidemiology. He's got more than 150 publications in academic journals, medical texts, and publications in medical textbook chapters. He's also an accredited participant in the Intergovernmental Negotiating Committee meetings of the United Nations Environmental Program to help prepare a global legally binding instrument on mercury, the Minamata Convention on Mercury. He's also addressed the Institute of Medicine of the United States National Academy of Sciences on multiple occasions regarding vaccine safety and policy. He currently serves as co-director and co-founder of the nonprofit Institute of Chronic Illnesses Incorporated. Dr. Mark Geier was invited to address the U.S. State Department Foreign Institute regarding contemporary genetics, the Institute of Medicine of the United States National Academy of Sciences on multiple occasions regarding vaccine safety and policy, and the Government Reform Committee of the United States House of Representatives on mercury and vaccines. He was also an accredited participant in the Intergovernmental Negotiating Committee meetings of the United Nations Environmental Program to help prepare that legally binding instrument on mercury, the Minamata Convention on Mercury. He's currently co-director and co-founder of the nonprofit Institute of Chronic Illnesses Incorporated. Please give a warm welcome to Mark and David Geier.
Thank you. Hi, thank you for inviting us to address you, and thank you for the years of support that this group has given to us that has helped us with our research. We have long since studied amalgam, mercury amalgam fillings, and it is mercury amalgam because amalgam means mixture of metals, so you have to include the word mercury. And many people have studied them and have found increases in mercury content in the urine in various places. But what has been difficult to do and what's been lacking is we know those things are bad for you, but what exactly do they cause or increase your risk of, and how much? And this has been difficult to determine because you need to have dental records along with medical records, and they're usually not kept together. And we've been looking at this for 20 years or more, and now we finally have things that we need to bring the question of, all right, they're bad for you, but do they cause or increase your chances of specific diseases? And that's what we're going to present today.
So this is a truly exciting lecture where we're going to present now 2 of our studies that have been accepted for publication in academic journals looking at the outcomes of arthritis and asthma. So those are 2 separate analyses. And we have a third part of our lecture which is going to talk about the levels of ongoing exposure among Americans to mercury from fillings, because we've all had our thoughts as to how many people actually have fillings and how many they have, but now we have good evidence, good data to tell you exactly at a national level. As my father said, of course, the missing link about amalgams is their relationship with human disease. We know there's mercury in amalgams, mercury comes off, mercury goes in the body, but what diseases does it potentially link to and how does it work? The great new source of data that we've been analyzing over the last couple of years is called the NHANES. That stands for the National Health and Nutrition Examination Survey. This is a survey that's done by our own government, by the Centers for Disease Control and Prevention. So it's a truly governmental database that was designed specifically to examine the health of the United States. The program of NHANES has been around for many decades. It began in the early 1960s. In the late 1990s, it became a continuous survey. So every year, the CDC, through its employees, goes out and actually samples thousands and thousands of Americans. It asks them all kinds of questions about their health status. It measures blood, urine, health outcomes, all kinds of different things. And starting in the year 2015, 2016, for the NHANES, for the first time, it actually examined dental amalgam filling surfaces or other surfaces. Prior to that year, there was either no information collected about dental filling status, or it was just simply a filled tooth or not. But finally, they incorporated the actual material that was used. So we now have access, because the NHANES keeps going forward, to data from 2015 through 2018, and we're able to assess the actual mercury vapor exposure in American populations. Specifically, our first study looking at the levels of exposure explored the relationship between dental amalgam filling surfaces and the risk of exceeding various mercury vapor safety limits. And we used the NHANES data to do that. We examined a population of adults between the ages of 21 to 66 years of age, which from the data we looked at represented over 158 million Americans are of that particular age group. Detailed information was available on every single person regarding gender, age, their race, countries of origin, socioeconomic status. It's filled with all of these kind of important variables. And each person was examined for their dental filling surface status by trained dentists that participate in the NHANES, and recording precisely how many fillings were either amalgam or other material, and we're able to compute the total number of fillings for each person. This is a summary of the actual 158 million Americans to show you how representative it really is. The NHANES is basically tied into like the census data. So you can see, for example, the racial distribution of this 158 million, 62% non-Hispanic white, 11% black, 5.7% Asian, Hispanics 15.9%, remaining multiracial or other. So that's exactly what the U.S. population is. The vast majority were obviously born in the United States, although there were some that come from other countries. And we then can see down at the bottom the exact number of people who have fillings. So in the United States, right now as it stands, 91,487,533 persons have one or more dental amalgam fillings in their mouth. That's not a guess, an estimate. That is a fact, or as close to a fact as we can get. 42.2% have either other fillings or no fillings at all. So that's 66,787,291. As far as the average number of dental amalgam filling surfaces, it is 4.2. So that includes people, again, who have amalgam fillings, no fillings at all. And for other dental filling surfaces, the average is 3.2. So what we're going to do now in the lecture is to briefly go through, this is basically an exercise in toxicology. I know this is a dental conference, but I wanted to show you a little bit about how we can actually calculate mercury exposure from a dental amalgam filling and translate that into a daily cumulative dose. So in order to do that, we used from the NHANES data urinary mercury levels. These were collected as random urines, and they were measured as micrograms of mercury per liter. The methods that were used to analyze the urine for mercury were consistent throughout the time, and the lowest level detection based on their methods was 0.13 micrograms of mercury per liter. One of the problems with collecting urine samples is that they can be random, as in they can go up and down over the course of the day. So in order to accurately reflect the amount of mercury exposure a person has over the day, you need to know how much is being produced over a 24-hour period. So in the context of this particular data, the way we did that was that each person, we took their random urine, micrograms of mercury per liter, and we used the NHANES data where they estimated how much urine was produced for each person per day. So we could take that spot urine and translate it into how much mercury would be produced over a 24-hour period. We then analyzed for each person their number of dental amalgam fillings versus their 24-hour urinary mercury levels to see what type of correlation might exist. And this is the actual correlations. What we do in these kind of models is that you produce what's called a beta coefficient. So this is saying if we take the total number of dental amalgam filling surfaces, this is the variable, and we look at the correlation with urinary mercury produced over a 24-hour period, this is the value that you get. So per surface filling over 24 hours, you get 0.041 micrograms of mercury per liter coming out in the urine. We then also analyzed to see how other variables affected that beta coefficient. So for example, things like race, age of the person, their gender, socioeconomic status, country of birth. And over on the right are the p-values, which represent how certain we are of these relationships. In science, we're looking for values of 0.05 or less, or we're 95% certain or more. We say those are statistically significant. We accept them as a valid measurement. So for the total amalgam surfaces, you see that it's very highly statistically significant. So indeed, total number of dental amalgam filling surfaces highly correlates with the amount of urinary mercury produced over 24 hours. When we take into account these other variables, the correlation slightly increases because some of these slightly influence it. Socioeconomic status and country of birth both have significant effects on urinary mercury levels.
The ones that are not less than 0.5 are not statistical, telling us that probably those variables don't affect it.
We then broke down the data by gender and by race, so we can look at this relationship between amalgam fillings and urinary mercury and consider how does, for example, being a male versus a female affect those beta coefficients, which are shown here. And then this is for each of the different racial groups. You'll notice that all of the p-values across all races, genders, they all remain statistically significant, but there is quite a bit of variability that's ongoing. So for example, among non-Hispanic whites, the males are 0.039, females are relatively similar at 0.038, whereas if we look at, for example, non-Hispanic Asians, for the males, beta coefficient is 0.06. What it's saying is that per amalgam filling, the amount of urinary mercury for an Asian person that's coming out is almost double or 1.5 times what you'd expect from a white person, a non-Hispanic white person. And you can see that perhaps the most remarkable is actually non-Hispanic black females. There's 0.072. They really are almost double. So there's tremendous variation based on race and gender. These are things that, as far as I know, nobody has ever considered or been able to consider in actually analyzing populations for mercury vapor exposure. Now, the difficulty or the complexity is that's just looking at urinary mercury over 24 hours versus dental amalgam fillings. You really want to know how much mercury is occurring in the whole body. So whole body exposure, not just what's in the urine, because we want to know the total dose. And people have done studies on this. It turns out that urinary mercury represents a relatively small fraction of the overall dose. It can be as low as 1/10 of it, so only 1/10 of the total dose actually comes out in the urine. That's for low dose exposure. As you get more and more mercury exposure, the urinary mercury level represents a much bigger percentage of the body exposure. And Mark Richardson, who I'm sure many of you have seen before, did detailed equations of how to explain that, and we incorporated that with our data. So the result is that when you do that, we did it for each person. We figured out how much micrograms of mercury their whole body was being exposed to, and then we divided by their kilogram body weight, which we had for each person. So now we are able to calculate the number of micrograms of mercury vapor exposure from dental amalgam filling surfaces divided by their kilogram body weight per day. This is their exposure from amalgam fillings. And to sort of consider those who had no amalgam fillings, those people obviously would end up with 0. based on the equations that are here. So they're included in these analyses. We have everybody from no fillings, no amalgams, to those who have many, many amalgam fillings. These are the various mercury vapor safety limits that are out there. The most lenient or the least restrictive one is put out by the United States Environmental Protection Agency at 0.048 micrograms of mercury per kilogram body weight per day. And basically it goes tenfold down all the way to California EPA, which adds in uncertainty factors and protecting babies at 0.05 micrograms of mercury per kilogram body weight per day. And so what we looked for was anybody that had a level of exposure that exceeded the safety limit. Anybody that exceeded it, we said they were in excess. Anybody below it was not. And so here are the actual numbers for the U.S. population. So when we take adults 21 to 65 years of age, the 158 million Americans, 10.4%, or 16,419,510 people exceed the U.S. EPA mercury vapor safety limit. And remember, this is just from their amalgam fillings. No fish, no power plants, no vaccines, just from their teeth. That's just spellbinding to me. You walk down the street and you see 10 adults, one of them, without even looking in their mouth, one of them is exceeding that safety limit every day of their lives as they go along. Obviously, as the limits start going down, down, down and become lower, by the time you get down to the California EPA, a majority of Americans, 54.3%, or 85,876,060, are in excess of the California EPA limit every single day. We can then break that down by the different racial groups that we have, because I know many people are often fascinated, is this occurring in blacks? Is it occurring in Hispanics, whites? What is going on? And it's a very strange pattern if you start looking at the various exposures. What you find are things like, for example, Asians as a group, non-Hispanic Asians, 15% of that particular population exceed the U.S. EPA limit. So they are the single highest group relative to that limit. But yet, not all Asians as a group tend to have amalgam fillings. It seems to be a very small group that concentrates on having a whole lot. As a whole population, if we look at the California EPA limit, it's only 43.9%, which is among the lower end of the different racial groups. And just looking at among non-Hispanic whites, we find that 56.5% are in excess of the California EPA limit. 64% of non-Hispanic blacks rather, are in excess of the California EPA limits. These numbers are just staggering. Absolutely staggering, and unfortunately, or I guess fortunately for us, nobody has ever done this before. We are the first to actually have these hard numbers. The previous one was actually males by those different racial groups. These are now the females, which are generally consistent, but females obviously weigh less than males, so that means that on an average basis, they exceed more of the safety limits. So if males and females have equal number of fillings, just based on weight alone, they're going to tend to be over more of the safety limits. And these are looking at the various risk factors for being over the safety limits. It's sort of a way of summarizing in terms of risk, what risk is posed by being, for example, if you're a female versus a male and you're comparing your risk of being over the EPA safety limit, females tend to be are 2.18 times more likely to be over the U.S. EPA limit than females. Interestingly enough, as you go to
males,
the males, as you go to more restrictive safety limits, males and females tend to be equally over. So again, it's skewed towards the least restrictive safety limits. As we saw before, race is very important. Repeatedly, Asians tend to be high. Blacks tend to be high. Interestingly, country of origin is an important factor in kind of a reverse way, which is that being born in the United States is actually, you tend to be more above the safety limits than being born outside the United States, implying either that less amalgams are being used in other countries, or simply dentistry is not as advanced, not as proficient at filling teeth as in this country. And of course, age is a big factor as well. As you get older, people tend to have more fillings. As they have more fillings, they tend to be over the safety limits. And age across all different safety limits is always a risk factor. We can also analyze the same data to see how many fillings an average person would need in order to be in excess of the safety limit, sort of a kind of a backwards way of calculating it. When we do that, we're able to determine, so for example, this is adult males, so this is an average adult male based on the weight and the number of fillings they have. If you have 16.23 fillings surfaces in your mouth, the average adult male will be above the EPA limit. It progressively is fewer and fewer as the safety limits become more and more restrictive, until finally you get to the California EPA limit, where between 1 to 2 filling surfaces would put the average adult male over the safety limit. And females, as I mentioned, same kind of pattern, but they weigh less, so less fillings are allowed. And for them, basically 1 filling would be enough to exceed the California EPA limit. So now moving on a little bit to disease, and this is looking at the same type of NHANES data to look at how diagnoses, in this case of arthritis, are related to dental amalgam fillings. Basically, we examined the same type of population as we examined in the previous slides, except this time we're simply looking to examine how many fillings the person had versus their risk of arthritis. It's long been suspected in the case of arthritis that there may be an environmental component that triggers an immunological stimulation that leads to autoimmunity, but people are sort of in the dark as to what it might be. Mercury certainly has been suggested. So we examined, as I said, the relationship between dental amalgam filling surfaces and the risk of arthritis in adults by examining this NHANES data. The way we did it was to compare those who had amalgam fillings. So that was one group that's shown on the left-hand side, dental amalgam filling group. All the different demographics that you've seen before that help to explain who they are. And then there are those who had, these are people who had no dental amalgam fillings. They had other fillings in their mouth. So both groups had fillings present. It's just a question of whether you had dental amalgams or other fillings without any dental amalgams. Overall, there were about, let's see, 85 million people in the dental amalgam group in this particular study, and about 32 million that were in the other filling group. When we examine the risk of dental amalgam fillings, this is looking at the outcome of arthritis, so that the top value represents the odds, the risk of developing arthritis as a function of having dental amalgams versus having other dental fillings, 7.68-fold. There's the p-value, highly statistically significant. We then analyze that same risk, examining race, gender, all of these different cofactors or covariates that might account for that relationship. And we find that the risk slightly comes down. It's still highly statistically significant, 4.89-fold, p equals 0.069. But we find that things like country of birth, as we saw before, is significant mediating factor, as well as age. Older people tend to have more arthritis and more amalgams. We then analyzed the data to determine how many people this actually affected, because the NHANES has these actual numbers. So what we find is that when we compare the rate per person year in the dental amalgam group versus those in the other amalgam group, the rate is about 6-fold higher. It's p less than 0.05. And then we can calculate what's called an attributable rate. this is the rate of arthritis that's due to amalgam fillings. So 5.3 per 10,000 people. And based upon the number of persons that we examined, we're able to determine 45,742 were reported to be newly diagnosed with arthritis attributably associated with their dental amalgam fillings. And when you factor in the cost of this, both the medical, which is $2,117 is the annual cost of having an adult with arthritis, plus lost wages, $4,040, we estimated that $96,835,814 US dollars are spent on annual medical costs, and $184,797,680 US dollars are lost in annual wages as a result of new onset arthritis attributably associated with the dental amalgam filling exposure. So now we've not only linked dental amalgams with an actual medical outcome, but we can determine the cost, and the total cost is over $281 million if you include both medical and lost wages. And that's on an annual basis from dental amalgam fillings in American adults. Interestingly, one final note on this particular paper is examining what the risk looks like as a function of dental amalgam exposure. So the vertical represents the incidence rate of newly diagnosed arthritis per 10,000 people. The horizontal represents the number of dental amalgam filling surfaces. So it's 1.05 or 0.6 in those who had no dental amalgam fillings. Slightly increases among those who had 1 to 1.15. And you can see that it precipitously goes up to 5.26, 8.53, 8.89. So there's a tremendous upward type trend, one little dip, and at 6, it becomes 12.7. So pretty obviously going almost like linearly straight up. But then interestingly, something unusual happens, which is for those who have 6 or more amalgams, it decreases. It's still way above what those who had none, but it went down to 5.81, and those with more than 13, it went to 2.41. So it's actually causing a stimulatory effect, and then it starts to decrease at very, very high numbers of dental amalgam fillings. This is the first time that I'm aware of that perhaps we've found that mercury not only causes a toxicity, in this case it may activate the immune system to cause arthritis, but at high enough levels it may actually be counteracting the immune stimulation to cause arthritis by damaging the immune system and starting to reduce the rate yet again. So not everything is simply it goes up. There may be peaks and valleys. There may be all kinds of distributions for different diseases with different levels of exposure, because mercury is such an exquisite toxin. And then turning to asthma, that was our other outcome. We examined the etiology of asthma in the context of environmental exposure to mercury. And this seems to be one that's kind of very often overlooked. We talk about mercury vapor from amalgams and how it may affect the brain, it may affect the liver, the kidneys, all kinds of different organs. But of course, the primary interface between mercury vapor and the human body occurs through the respiratory tract. That's where all that vapor particulate is coming off. So in this particular study, we're looking at how numbers of dental amalgam fillings may modify the risk of newly diagnosed asthma in the NHANES. And this is very similar to the previous slides about the age groups we looked at, the distribution. One thing that we did consider in this particular study is that we actually looked at smoking. Cigarette smoking, you can measure exposure to that based on this serum protein. So we actually looked at that because we thought that that might be an important mediating factor in the relationship. So we looked at that as a covariate. What we find is that the risk of asthma is very significantly increased, and this is newly diagnosed asthma. It was 4.46-fold increased among those who had dental amalgam fillings versus those who had other fillings. And again, the p-value less than 0.05, so it's statistically significant. And then this is considering that same exposed versus unexposed, looking at the various other covariates that we had, race, gender, and so on. Interestingly enough, here's the serum protein. So this is cigarette smoking. You notice that you can't just say that it's people who have amalgams, maybe they smoke or something like that. The effect remains significant. As a matter of fact, in this case, it slightly went up, and it's p less than 0.013. And once again, we're able to calculate the actual number of adults, Americans, that this affects. And based on our data, we found that the rate was increased about 4-fold, and that when we looked at the attributable difference, which in this case would be the rate difference per 10,000 people, comparing those who had the amalgam fillings versus other fillings, it was 1.50 per 10,000, which when you do the math, it translates out to 14,679 persons each year are newly diagnosed with asthma attributable to their dental amalgam fillings. The direct cost of asthma from the published literature is $3,259 per person per year. And so the cost on an annual basis of asthma attributably associated with dental amalgam fillings was $47,838,861. And of course, asthma is a chronic disease. It's not like you have it and it goes away. So we did some extrapolation out to something like 25 years, assuming they would have it for most of their adult life, and you end up with in the trillions of dollars of damage from dental amalgam fillings. This is a slightly different analysis. This one is examining the actual dose dependency. In the previous work we did on arthritis, I mentioned it went up and then it came down. So there was some dose dependence, but it was not a clean, clear dose dependence. In the case of asthma, it's very distinctly dose dependent. So what we find is that the risk, so this would be the risk of developing asthma is a function of dental amalgam filling surface. So per dental amalgam filling surface, the risk is increased by 1.073 or about 7% per filling surface. And it's highly statistical. And then we examined various other ways, looking at it with these various cofactors. It actually stayed identical, no difference at all. And we even considered looking at, when you look at other fillings with the amalgam fillings, you see that other filling surfaces didn't increase the risk of asthma whatsoever. It's a distinctly dental amalgam effect that's going on. So to put these new findings in kind of perspective of what's happening, what we're demonstrating is for the first time that dental amalgam fillings are actually resulting in American adults receiving mercury doses or mercury vapor exposure from their dental amalgam fillings in excess of safety limits. And we're not talking about just a handful. We're talking about tens of millions up to almost over 100 million American adults. And if we factor in, as we've done in other analyses, children, teenagers, the elderly, the amount of exposure is just overwhelming, just from the fillings without any environmental exposure whatsoever. And it puts something kind of in perspective for me, which is, I'm obviously not a dentist. My father's not a dentist. We go around and we talk to people all the time, and it's amazing. Every dentist that we run into, we travel, you're a dentist, what kind of fillings do you place, what kind of practice do you do? Everybody we run into, nobody has placed a dental amalgam filling. 5 years, 10 years, 15, never did it. What craziness? Well, somebody is not telling the truth. You don't have 100 million Americans having fillings in their mouth and nobody's placing fillings. Somebody is doing this around the clock, obviously. So that's a very important point. And with this information, you can actually target, as we showed, who it is. It's no longer some mystery. Is it minorities? Is it old people? Is it young people? We can actually explore all of that and know who it is. Further, with our epidemiological studies, we're showing that it's not just exceeding safety limits. Safety limits suggest that harm should be done. That's why we have safety limits. but that it's actually demonstrable medically diagnosed conditions, arthritis, asthma, and we're working on many others. Now, the effects remain significant, as we saw, considering covariates, because people often say, well, what about race? What about gender? What about? Well, it turns out when considering a lot of them, the effects remain significant. And in addition, the societal impact of these things are enormous in the millions and billions of dollars. These are things that are going to cost our society for my whole lifetime. I'm sure I'll be paying taxes, just like all of you, to help support these people who are being damaged by amalgams. It's a moral, medical, ethical, every kind of imperative that we find a way to stop this, stop the ongoing damage as in placing new amalgam fillings, and for those who have it, obviously using safe and appropriate techniques, both dental-wise to remove them as well as medically to try to treat their symptoms. These are all things that have now become front and center with our work.
And now, for the first time, if someone says, all right, big deal, we put in mercury, yes, you found it elsewhere in the body, big deal, what harm did we do? Now you can tell them.
We know that it's causing medical harm. We know
what medical harm it is.
And we were going to expand that circle further and further, and we can quantify how many people are at risk by those safety limits. Now, this is very interesting, which is that we seem to have entered a very golden period in our scientific studies. I don't know whether it's COVID or many of you may or may not know, my father actually got a kidney transplant last year.
That's why I'm sitting down.
that we have been really thinking and doing a lot of research on various things. And I know that many people over many years coming to these conferences have suggested that we should be looking at fluoride. And we've listened and we've heard people give lectures on it, and we've never really thought of a way to be able to do it. Well, I'm going to briefly show you an outline. I think that we can now do that with some funding. We could actually do studies on fluoride and its potential medical effects. As this slide says, a quick look out in the literature finds that while sort of there's some consensus that fluoridated water and fluoride in general can cause toxicity in humans, there is a real lack of studies of prospective, particularly American children, to evaluate what does fluoride do as far as medical diagnosed conditions. This seems to be a reoccurring theme. It's the same thing with like the amalgam fillings. People have shown that mercury is toxic, but can you show dental amalgam fillings are linked to medical diagnoses? Well, same issue is sort of ongoing with fluoride. People have shown in various animals and limited studies that it may be toxic, but what medical kind of conditions does it cause? And what we have access to that would, I think, directly let us be able to study this and to begin to really ask the questions, because the moment you start having the ability to ask these questions, your mind completely runs wild. What we have access to is what's called the Independent Healthcare Research Database, which is made up of Florida Medicaid-generated records. It's de-identified, so we don't have names, addresses, and phone numbers on the people. They simply have a unique identifier. And each person, again, has detailed information about their race, their gender, dates of birth, where they live. And as you, I'm sure, are all aware, it turns out that where you live is very important for fluoridation exposure. Not every water supply has fluoride. Some use more, some use less, some have more households that are using fluoridated water than others. And in the state of Florida, we were able to get access to the Florida Department of Public Health information by each county by year, directly overlapping with our Florida Medicaid data. So if we have a child, for example, that was born in, let's say, 1995 in Palm Beach County, we can, from the Florida records, know what their chances of exposure to fluoridated water were. So each child has a specific exposure variable, and we are able to examine these children, and it's not just children, but this particular study was contemplating looking at children. we can examine them from birth to, let's say, age 10. So they have 120 months of continuous enrollment in Florida Medicaid. We make sure that they're actively utilizing the Florida Medicaid services. And when we went through, we were able to find a cohort of 73,254 children born between 1990 through 2002 that have all of the specific race, demographic type of information, and that we were able to link it to their fluoridated water exposure.
And this is a database that was given to us by the governor of Florida, Charlie Crist. It was not a database. It's just a list of, if you're a doctor in Florida and you have a Medicaid patient, you send in a bill, and they wrote the bill down. And we spent 10 years or more assembling that into a usable database, because, you know, you have one bill 1 year and 12 years later is the next bill for that patient. You have to make charts out of them. And now we have it completely under control, and now we're able to do this study. And by the way, there are 3.3 billion records that we have access to. Not million, billion records.
And I also should mention there's some people that deserve some very special thanks that are here. Mark Ellefeld is somebody in the audience, and Chris Homey. They are people that have personally given tremendous support, help to allow us to be able to do this. And so this is the kind of breakdown of the kids that I was mentioning that we could do this kind of study on. And it's fairly representative, meaning that it has males and females. It's not unusually skewed in some ways. It has obviously a fair number of minorities, being Medicaid. That tends to, at least in the state of Florida, skew towards minorities, but it still has many whites and others that are present in it. And the bottom is the summary of the kind of exposure to fluoridated water. What we are able to look at is fluoridated water by household. So you could have a county that had 0 households that had fluoridated water exposure all the way to 100%. So during the course of the data that we have, the average was 65.7% of Florida households were exposed to fluoridated water with a median of 83.1. So there's a lot of variability in the data, which is exactly what you want. You want a place that has some moderate high that would allow you to be able to do the study. And then in this data, because we're able to follow the children, we can examine their rates of various diseases. So this is a quick summary of some of the neurodevelopmental type disorders that were diagnosed in these cohorts of kids. And the rates in the way we've assembled the Florida data are, I think, very representative of the true population rates. So this is not like we're picking up 1% or 5% of the kids that have neurodevelopmental disorders. These are the rates as good as any that I've ever seen published. So for example, if you talk about ADD, ADHD, the incidence rate in the first 10 years of life among the kids that we could study would be 22%, almost 1 in 4, which is an enormous rate, which means that if something like fluoride was potentially linked to this, think of how many children, using our risks and our attributable risks, how many children might actually be might potentially be affected by it. And we have other ones like autism, tics, mental retardation. An interesting one, I believe in the last IAOMT lecture, there was presentations about looking at IQ deficits linked to fluoridated exposure. We could actually look at different levels of deficit of mental retardation as a function of their fluoride exposure. And the way we would do it would be logistic regression, where we can examine fluoridated water supply as the exposure variable. It's a continuous one. It's something like birth, but I should emphasize here's an example where mind can run wild. Is it at birth? Is it at 1 year, 2 years, 3 years, 4 years? Is it cumulative? How does any of that work? I don't think it's been very well studied. And then the long-term incidence rate of the various types of outcomes examined, and again, considering all these covariates, gender, race, birth, date of birth, etc. And so that's the end of our talk for today.